Welcome to Better Health Guy Blogcasts, empowering your better health. And now, here's Scott, your Better Health Guy. The content of this show is for informational purposes only and is not intended to diagnose, treat, or cure any illness or medical condition. Nothing in today's discussion is meant to serve as medical advice or as information to facilitate self-treatment. As always, please discuss any potential health-related decisions with your own personal medical authority.
Hello, everyone, and welcome to episode number 68 of the Better Health Guy blogcast series. Today's guest is Dr. Jyotsna Shah, and the topic of the show is IGeneX. Dr. Jyotsna Shah is the president and laboratory director of IGeneX Clinical Laboratory in Palo Alto, California. Dr. Shah has over 40 years of research experience in immunology, molecular biology, and microbiology, has been published, and holds more than 20 patents. After receiving her bachelor's and master's in biological sciences in the UK and her PhD in diagnostic immunology from Nairobi University in Kenya, Dr. Shah joined the International Laboratory for Research on Animal Diseases as a post-doctoral scientist and started the first DNA sequencing laboratory in East Africa. On completion of her fellowship, she went on to join Harvard University's Department of Tropical Medicine as a research fellow and continued work on development of molecular tools for diagnosis of parasitic diseases. Since then, Dr. Shah has worked at several biotechnology companies focusing on the development of novel molecular technologies for the diagnosis of infectious diseases and has become a world expert on the use of Fluorescent In Situ Hybridization, or FISH technique, for direct detection of pathogens in clinical samples. Dr. Shah joined IGeneX as the Director of Research and Development in 1997 and in 2003 became Laboratory Director. During her time with IGeneX, she introduced the first fluorescent in situ hybridization test for Babesia and also set up the PCR department for Tick-Borne diseases. Under Dr. Shah's direction, the laboratory has developed an excellent QA program, and with her scientific guidance, IGeneX has become the world's leading reference laboratory for the diagnosis of tick-borne diseases. Dr. Shah is now the owner of IGeneX and continues her mission to help those struggling with vector-borne illnesses. And now, my interview with Dr. Jyotsna Shah. Today, I am very excited to have Dr. Shah from IGeneX with us to talk about laboratory testing for vector-borne diseases such as Lyme disease. And I first wanted to just congratulate you on not only your new tests, which are fantastic to really see diagnostic tools emerging and continuing to develop in the realm of Lyme disease, but also your new website is fantastic as well. So thanks for being here, Dr. Shah.
Thank you, Scott. I look forward to talking about Lyme disease and what we have done in the last 25 years.
Excellent. So you initially worked with tropical medicine and parasitic diseases. How did you then get drawn into the world of Lyme disease? Did you have a personal experience with Lyme disease, or was it just a natural progression of the work that you were doing in laboratory medicine?
Let me explain what happened. When I first came to States in 1984 as a research fellow at Harvard School of Public Health, one of the hot topics was Lyme disease. And the epidemiologist, world-renowned epidemiologist, Professor Andy Spillman, had started working on Lyme disease, had found white-footed mice in Nantucket infected with Borrelia burgdorferi. So the whole project, we had ticks in at our institute, they were being infected. So we were hearing all the basic stuff and all the new science that was going around in Lyme disease. So I knew quite a bit about it. And my first job, I decided I wasn't going to be in academia. I wanted to have a family life. I didn't want to spend my weekends writing grant applications. So I joined a biotech company. And as it happened, the colleague I was sharing my office had worked with Borrelia burgdorferi. Had just come from there. Not only that, they had looked at different Borrelia groups, had published a paper in Science, and his family had Lyme disease. So I used to hear a lot. He came from Long Island. So we started talking, we would discuss things and what was going on, just as colleagues, and both of us being in molecular biology as well. So when I was making a decision as to what do I really want to do with my life? Do I want to take the path of genetic diseases, or do I want to be in infectious disease? And somehow I was drawn more towards infectious disease, maybe with my background in tropical medicine and what I'd learned at GeneTrek at the time. So this is how I ended up coming to IGeneX. And of course, when I first came at IGeneX, my goal was to do research. That's what my background is. But Dr. Nick Harris had other ideas. He wanted me to, he was a very good planner. He wanted to have somebody to run his clinical lab and take over. So he trained me in kind of got me into the clinical side of things as well. I used to spend a lot of time with the pathologists at the time. And eventually I ended up running the clinical lab as well as running the research at IGeneX.
Excellent. I had the opportunity to meet Willy Bergdorfer one time, and that was certainly something that I appreciated, having that opportunity. So that's nice. Tell us a little bit about the history of IGeneX. I just recently realized, and I knew you had been there for a while, but you've actually been there for 20 years, right? Over 20 years now. And now, of course, you're the owner of the lab, having taken on the work from Dr. Nick Harris. And so tell us a little bit about the history of IGeneX, how it was started, when it was started, why it was started.
Okay, Dr. Nick Harris used to work for 3M Diagnostics, running the allergy testing lab. But 3M decided that this wasn't a business they wanted to be in, and they wanted to close the lab down. So Dr. Nick Harris decided to take over that lab, buy it out, and run an specialized allergy testing lab. That is how IGeneX started in 1991. By 1995, they had added Lyme disease testing to their menu. And by 2000, the decision was made to stop allergy testing and focus on Lyme and associated diseases. Since then, that is all we've been doing.
Excellent. Yeah, that's interesting because I didn't even know that that's how IGeneX was started. So I'm learning some new things today as well. Let's talk a little about antibody testing versus antigen testing. What are the pros and cons of each? Is one better than the other in terms of Lyme disease, or should they be combined? And then are there some people that never make antibodies even though they may be infected with Borrelia?
Okay, let's start with how do we look at any infection? We look for how a patient responds to the disease, and that's where antibodies or T cells would come. And then you look for the pathogen itself. That's the part of the pathogen. This is known as the antigen. And then we also look for the DNA, the genetic makeup of the pathogen, because that has specific signatures that we can look for. So in reality, to get a full picture, one should do a panel approach. And I'll explain why. Early in the disease, when a patient gets infected, the first target would be T cell. It's a cellular immunity. That is what will be that will target the pathogen to try and capture it and kill it. So you see a T cell response. Then you will also, at the same time, the pathogen starts multiplying. And therefore, if you did a PCR test that's looking for the DNA piece, you can find DNA pieces. So these are direct tests that you would have to do early in the disease. Sorry, T cell is not a direct test, but antigen test would be direct. Right. T cell is a new test which we have started working on. So that does seem to help. I don't know the sensitivity of that test to make a comment, so I would suggest we do both tests. Antibody is the patient's response to the pathogen. And the first antibody that comes up is the IgM antibody and then the IgG, but in Lyme, IgM can persist for a very long time. And to your second question, yes, there are about 20% to 30% of patients who do not make antibodies. Now, in that case, you have to look for the pathogen itself. So therefore, when you do not know what the status of the disease is, whether it's new disease, is it late disease, or whether the patient can make antibodies, and even if they make antibodies, what we are finding is some patients may just make G, some may make M. This is rare, but we do find that. So really, to get the true picture of what's going on, our recommendation from our experience is to always go for a panel approach. Because what we find, just to give an example, at some stages, you're going to find all tests positive. Early in the disease, you'll get IgM response, probably positive, PCR positive. But in the middle, it's only going to be IgG and IgM antibody response that's going to be positive. Later in the disease, some patients will have low levels of antibodies. Some will have antibodies plus DNA. We might be able to detect. As we go through, you'll understand why. But that is why I would like to emphasize that the panel approach is very, very important.
Yeah, that makes a lot of sense to me. And my understanding is even with the Western blot or the Immunoblot, even the IgM, that it still takes some number of weeks from the bite of the tick or other vector before even that would show, correct?
Correct. Minimum 7 days is what, in a few patients you'll see that, but I would say between 15 to 1 month.
Okay. So let's talk a little more about the antibody testing piece. So in most infections, people say if you have IgM, that's recent infection. If you have IgG, that's past memory, may not even be an issue. But in Borrelia, my understanding is that is not true, that the Western blot or the Immunoblot can even have this kind of cycling where it goes from IgM to IgG and maybe again back to IgM as the immune system is kind of seeing, not seeing, not seeing this organism. And so when I hear people say, well, my doctor said that it's old infection because my Western blot shows only IgG, my understanding is that may not necessarily be true. So can you talk a little bit about that?
Yes. What we find is early in the disease, it's always IgM. Then in most patients, we see IgM converting to IgG. But in some patients we always see low levels of IgM present. And then IgG goes down, but the IgM low levels remain. In other patients, what might be happening, just like in case of tuberculosis, when a patient gets infected with TB at an early age, they may have no symptoms, just what we see in Lyme as well. But the pathogen goes into hiding. In case of TB, it hides in bones, for example, in case of Borrelia in tissues under biofilms. And you may not have any symptoms because your immune system is strong. But when at a later stage, your immune system is weaker it could be due to any reason. You have another infection, you could be on some drugs, for medical reasons, any of that can trigger this low response for Borrelia to come out and that low IgM response, and that can cause disease, the chronic or late stage of the disease. So in fact, in the chronic or late stage of the disease, we usually do find IgM antibodies. And sometimes it's PCR positive as well. But there could be cases where IgG is present and a patient can still have an active infection. Just to give you an example, in Morgellons patient, we have seen patients who have IgG antibodies late in the disease, very few, but IgG, and they are PCR positive. These are patients with active Morgellons disease, whereas in other patients, we will only see IgM, and it remains as IgM even after a year. Another example of Morgellons disease patients. For Lyme, it's a very, very complicated picture we are looking at.
So it sounds like my understanding is consistent with what you're suggesting, that you can't necessarily conclude how recent the exposure is just from IgM or IgG like you can fairly reliably with other types of infections.
You are absolutely correct. And this is why we keep on saying, we need a panel approach. Because then if you see an active disease, if you get PCR to be positive, which is like 30% of the times at most, then you really have a good picture. Even though it's IgG or IgM, from what I've just told you, then you know the patient has active disease. It's a confirmation.
Very good. Thanks for that clarification. So one of the differences historically with IGeneX with the Western blot as compared to other commercially available Western blots is that IGeneX does look at and consider bands 31 and 34, where other commercially available tests do not. So why are bands 31 and 34 important, and why are they excluded from many of the other commercially available testing?
Okay, this why are they important was described by Ma et al. In 1992. This was a group working with Nick Harris. And what they found in their studies, it's well documented that 31 and 34 are not the most common antigens, antibodies to that, but how they are detected in the later stage of the disease. Okay, so that made sense. If you really wanted to look at the full spectrum of the disease, you do need to have all the antigens on your blots. That is why it was included. However, when it came to CDC or the guidelines, what happened was there was a vaccine under development using OSPE. So, of course, if you're developing an vaccine and patients are vaccinated, it's going to give a false positive result on your Western blots because you already immunized them with that antigen, so your antibodies to that are going to be present. So you can't use it as a mark.
And my understanding is that vaccine has not been available for 15 plus years now, and yet we still have this kind of carryover to not looking at. And OSPE is one of the important outer surface proteins of Borrelia, and so sounds like it would be important to look at, which is probably why you are looking at it, right?
Absolutely. The vaccine was taken off in 2002 because of adverse reactions in some patients causing arthritis or neurological symptoms. We all know that OSPE is very important for arthritis, causes arthritic-like symptoms. It should have been changed, but when you think about it, CDC has done nothing. They have not gone with the times. There's been so much information out there on Lyme disease since the guidelines were set in 1994.
Wow.
1994, we are talking of 24 years now. And they are just behind. I mean, they've had discussions where they were going to add PCR about several years in 2012 in a closed meeting, but nothing has happened. I'm hoping that with the working groups and the teams working together, that there are going to be some changes, hopefully.
Yeah, fingers crossed.
Yes.
I agree. That would be fantastic. So on the Western blot, which bands does IGeneX consider to be Borrelia specific? And then do those same set of bands carry over to the Immunoblot, which was released at the end of last year? Or is there a difference between the bands that we look at between those two tests?
Okay, on the Western blot, we look at 23, 31, 39, 23, 31, 34, 39, and 41 on the IgM blot. Okay, and on the IgG, we look at it 23, 31, 34, 39, 41, and 93 on the Western blot. Now, if on the Western blot, we always stated that if 31 and 41 were present, that it was indeterminate. Whereas on the Immunoblot, we have the same bands on G, but on M, we have eliminated band 34. And the reason we have done that is band 34 is not as specific as we thought earlier on. And on M, when we looked at it, we hardly ever found it in real, well-defined samples.
Okay.
So we've looked at over 200, probably 500 samples now. And based on the studies, we are not including 34 on M, but on G, it's important.
Okay, very good. So, and these bands are the ones that IGeneX considers for the IGeneX result, but not necessarily the same as what the CDC considers in terms of the surveillance criteria, correct?
Correct, because for CDC, they use 23, 41, and 39 for IgM. So they are not using the 31 band that we are using for IgM. For IgG, they use more bands, but they do not use 31 and 34. Instead, they were added band 66, band 58, band 45, band 30, band 28, and 18. When we have looked at the data, we are finding that these bands are not specific for Lyme, Borrelia burgdorferi. They may some of them will cross-react with other disease, other pathogen antibodies. So we don't like to use them, but on our Immunoblot, as we used to do on our Western blot, we do report by CDC criteria and by IGeneX criteria.
Okay,
so the physician has option to decide what they want to use.
So you mentioned band 41. When someone sees band 41 on either a Western blot or an Immunoblot, my observation has been that that's very common to see and that it may not necessarily indicate Borrelia. So are there other organisms or factors that could lead to a positive band 41 that then do not necessarily indicate Lyme disease?
Yes, it's a flagellum band. Several bacteria have flagella. For example, Treponema palladium, which causes syphilis, it will cross-react to that. Periodontitis, Borrelia, spirochetes that cause periodontitis, it will cross with that. Maybe other flagellum bacteria as well. So it's not specific. However, when we combine it with one of the other specific bands, statistically, we were able to show that as a part of the group, it's important to include in our reading criteria.
And then band 31, you talked about, OSP-A. On the Western blot, there was always the possibility that even though it's fairly indicative of Borrelia, there was a possibility that it could be cross-reactive with certain viruses and potentially other organisms. So what are some of the things that band 31 could have told us other than Lyme on a Western blot?
Okay, we know from our studies that EBV, Epstein-Barr virus, antibodies that do cross-react with band 31, Treponema palladium, antibodies to that do cross-react with them, hepatitis C virus, antibodies cross-react with them. We have enough data on that. The reason is when we make a Western blot, all you're doing is you're taking the whole cell lighted with thousands of proteins there and separating them by size. So at any one position, you can have more than one protein. Some of them are just housekeeping genes, which are found across the spectrum. Others could be specific. For example, at position 31, there are two proteins that are present. One, we call it a housekeeping gene because it's found in viruses even, as we were saying. And the other one is OSP-A, a very important Borrelia burgdorferi specific protein. So on a Western blot, when you get a positive signal, it may be due to the specific band, OSP-A, or it could be to the housekeeping gene, which is crossing with a lot of things. And in our experience, we found that it's almost 50-50 chance that it's going to be specific. So once we learned that, we developed the Epitope test for confirmation. And the reason is, as I mentioned, OSP-A is a very important marker. We did not want to lose that marker. So we said, how do we make use of this? There's no point in everybody doing the Epitope test. Number one, because if you don't have band 31, it's going to be negative. So we have to have the Western blot. And then we'll say if it's necessary, you do the confirmation test. Now, when we move to the immunoblots, every protein, we can decide, we decide what we are going to put on it. It's made manually. We use purified recombinant antigens. So at one position, there is only one specific protein. And therefore, OSP-A is there, but the housekeeping genes that were cross-reacting have been removed from our immunoblots.
So no more requirement to do that confirmation test with the Immunoblot, which is great. Yes. And just for people that are kind of not clear yet with the Immunoblot, and we're going to talk about that, but that's essentially kind of becoming, for most scenarios, the replacement for the Western blot. It's kind of the next generation of the Western blot is how I think of it. Now, looking back at band 31, again, you mentioned some of the things that could cross-react. I've heard some people suggest that even possibly chlamydia pneumonia and maybe even mycoplasma. Do you know if those could also be cross-reactions or no?
I am not sure. I
Okay.
haven't seen that.
Okay. So let's talk a little bit then about the Immunoblot. So as I understand, like we just talked about, that essentially replaces the Western blot. I believe, is it true that in New York, they still only have the Western blot or cannot order the Immunoblot, or is it available everywhere now?
No, right now it is not. We are working with them and we are hoping that it will be allowed very soon.
Okay.
They've looked at some of the data already, and we're working with
So eventually it will replace the Western blot. The Western blot was very specific to Borrelia burgdorferi, and as I understand, did not necessarily identify other Borrelia species, European Borrelias like Borrelia afzelii, Borrelia guarinii, things of that nature. So it sounds to me like the Immunoblot is broader in terms of the Borrelias that can be identified. So can you tell us a little bit about the differences from that perspective?
Yes. When we think about a disease, we all know that Borrelia burgdorferi is found in US, everywhere now, really speaking, and in Europe. People travel a lot, number one. So you don't know where you picked it up, whether it was on the West Coast, East Coast, somewhere, or in Europe. So when we decided that if we were really going to develop the second generation test, we wanted it to be inclusive. That doesn't matter where you got tested. If you ran this Immunoblot, you will get an answer, whether you were infected or not. That was our goal. And if we were to do Western blots, we would need to do at least 7 for each one, minimum. That's expensive. We can't make it. It's not practical from a clinical lab point of view to synthesize those kind of Western blots. So we decided we had to come up with an Immunoblot and see how we can make it affordable with the information we want to provide. And so we have developed an Immunoblot that will detect the European species, Afzelii, guarini, valenciana, just to name a few, and also the newly found Mayoni in US. And, when the Western blots were developed in the 90s, we didn't have all the information about different species that are present even in US. Now we know there are more. And when we published the paper in 2010 with our Western blots, we clearly showed that even with V31 and 297, by including 297, we're detecting more patients because there are variants. So taking what we knew, now we have developed the Immunoblot that we believe is the most inclusive that you can get today.
And for people that want to understand a little more about specifically which organisms it covers, there is information on the IGeneX website that goes into detail, lists the different types of Borrelia. And so I think that's great as well. You guys have a lot of really good information on the site at this point. In the past, doctors would, in some cases, pre-treat with antibiotics to try and get an immune response to Borrelia with the Western blot. And I'm curious if that same strategy still makes sense with the Immunoblot.
Basically, we are looking for antibodies, correct? Whether it's a Western blot or an Immunoblot. So whatever was done to improve the antibody production will help Immunoblot. So the answer is yes.
That makes sense. And then do we know the sensitivity and specificity of the Immunoblot, how that compares to the prior Western blot?
Yes, we do. We have done extensive studies looking at Western blots and comparing it to the Immunoblots. When we looked at it with well-characterized samples, and in this, I mean taking CDC well-defined samples as well, our sensitivity for Lyme Western blot was 89% for IgM, and IgG was 93%. With Lyme Immunoblot, sensitivity of the test with Western blot was 69.2% for IgM, and 69.2% for IgG, with an overall sensitivity of 84%. With the Immunoblot, our sensitivity for IgM and IgG is 88.8% and overall 96%. We are finding that by having a more inclusive Immunoblot, our sensitivity has gone up with well-defined samples. Now, going to the specificity for Western blot, without using the epitope test. Okay, this is what I'm giving you. It's 89.5% with the same set of samples. With the epitope, it goes up to 98.7% for IgM. With the Immunoblot, it's 100% for IgM. We are very surprised, but this is on the set we have done. But it's really excellent. And then for IgG, it was 93.4%. With the epitope, it had gone to 96.7%. And with the Immunoblots, it's 97.4%. So it's really, we have not lost any specificity. This is equivalent to the CDC tool-tier criteria, where you're almost 100%.
So it sounds like if it's 100% specific on the IgM immunoblot, which is, I believe, what you suggested, that if you get an IgM positive immunoblot, there is not a likelihood for a false positive result, that it is very specific. Is that true?
It appears like that from our studies, because we looked at a big panel of viruses, which is where the problem was really with 23. Now 23 is very clean. So I suppose that's why we got really good specificity. I mean, I hate to say 100%. This was with a set data. We really would have to do a much bigger pool before I would say. But in this set, it really looked much better than Western blot. And when we looked at it, it was really the viruses that were giving us false positives. And it seems to really clean that part up.
So it's a significant improvement from the Western blot is really the bottom line. We're moving in the right direction in a significant way, which is great. Let's talk a little about the tick-borne relapsing fever immunoblot. So there's two different immunoblots. What is the relapsing fever Borrelia? What is a relapsing fever Borrelia? Okay. And then what specific species is the tick-borne relapsing fever immunoblot detecting?
Okay, so we don't there's very limited information that people hear about in terms of tick-borne relapsing fever. Tick-borne relapsing fever, Borrelia, is a group of Borrelia that cause relapsing fevers, basically meaning fevers at set intervals. And most, maybe people are aware that the species that was well known during the World War was Borrelia recurrentis, where millions of people died because they were living in close quarters, and it's a disease. It's a Borrelia that's transmitted by head lice. So when people were living in these close quarters, that during the world wars, millions of people died from there. But besides that, you don't hear much about it. It's found everywhere in the world. And what brought it to light here, on the West Coast, people knew about Borrelia hermsii and Borrelia turricate. There were classical cases where they did see relapses, fevers with relapses, and these are documented. Very few cases you will find them. However, relapsing fever was put on the map when a patient had neurological Lyme-like symptoms. This was by the team headed by Sam Telford in Boston. When they were lucky to have isolated the Borrelia, and they sequenced the Borrelia, and they found that it was Borrelia miyamotoi. This is in the same group, tick-borne relapsing fever group. Now, they found a Borrelia with Lyme-like symptoms. And in Europe, they had found it several years back. There were several cases where some of them had traditional relapses, some didn't. Some had Lyme-like symptoms. Since then, and we had already started looking at it from a broader spectrum. And so we decided, as we have done with all our tests, that we want a test that's going to be inclusive of tick-borne relapsing fever Borrelia. Doesn't matter where the infection comes from. And and this is how our immunoblot has been developed. We know that we can detect Borrelia hermsii, Borrelia miyamotoi, Borrelia turricate. These are the three common species. We believe, based on the sequence information, that we will detect Borrelia pachyeri, but we don't have a case to show that it does. And Borrelia coraceae. And so we are very comfortable saying that this is a fully inclusive test. We have tested this in Europe, In Ukraine, we did a study on over 200 patients and in forest regions, and were able to show that the same species of Borrelia that's called relapsing fever that's causing disease here also is found there.
And my understanding is this test may also be helpful for people in Australia. Is there a specific Australian Borrelia that this test identifies?
It does identify, I'm going to back off a little bit before I answer that question. What we have seen is there is some cross-reaction between different tick-borne relapsing fever Borrelia in the antigens that we have chosen, which are very specific for tick-borne relapsing fever. With our study on Australia on 100 patients, we have found almost 20% to be positive for tick-borne relapsing fever.
Wow.
We had seen that earlier, even with our Western blots, that there were patients positive, but even with the immunoblots, we've been able to confirm that that's really the case.
And which Borrelia is it that's more commonly seen in the Australian population?
It's closer to Miyamoto.
Okay.
It's Terracardia Miyamoto. It's a mixture when you look at it. It's not as clear cut. So that's why I don't know I don't know the species. It's the bottom line. But they do have hard ticks there.
So in someone that has Lyme symptoms, how common would it be to have a negative Lyme immunoblot, but a positive tick-borne relapsing fever immunoblot? In other words, if someone orders a Lyme immunoblot and it's negative and the person has symptoms consistent with Lyme, should their practitioner then order the tick-borne relapsing fever immunoblot?
Yes. And I'm just going to give you some statistics that I have from Europe. So we did this study on, as I said, there were 149 patients that were, that we looked at in this group, and 40% of these were Lyme positive because these were forest workers. And out of that, 40% had Lyme, 11.9% had relapsing fever antibodies, and 13.2 had mixed infection in this group of patients. So it's quite common to get both infections in places where you have hard ticks and soft ticks. Now, what's become even a bigger issue is now we know that hard ticks also transmit tick-borne relapsing fever. So in areas where we were only thinking Lyme disease before, and that might have been the reason when patients had the symptoms, but the tests were coming back negative, it could have been tick-borne relapsing fever. So it is very important to test patients with Lyme-like symptoms with the Lyme immunoblot and the tick-borne relapsing fever immunoblot.
And is there a possibility that those two tests might be combined at some point in the future, or is the plan to keep them separate?
It's possible we may combine it as one test. At this point, for technical reasons, we are not combining them. We do need to learn a little more about it, just so that we are very clear as to what's happening. It's a learning curve for us. There isn't much information out there in terms of species. Are we able to better speciate as we go down the line? I'm sure we'll understand it better. What are we finding in different areas? There are a lot of questions that we need to answer before we combine everything together.
Makes sense. So we've talked about the Western blot and the immunoblot. I want to talk about a few of the other tests and technologies that you offer people. So is the Lyme IgG serology, is that essentially what people refer to as an ELISA?
Yes, you're correct. That's what it is. According to the CDC, that's the first test you do, a screening test. Now, what is a screening test? A screening test should be something that's going to be very sensitive, and it can have some specificity issue because you're catching everything first. Unfortunately, with the ELISA or the C6 ELISA, we don't have the sensitivity required. The best is around 73%, 73 to 75% with the ELISA or C6. With the C6, in our hands, what we have found, it doesn't perform well early in the disease or late in the disease. So it's not a good marker. It's as a screening test, it fails us there. With the ELISAs, you do detect it, but C6 has excellent specificity, 96%. but it misses. Sensitivity is a problem early in the disease and late in the disease. With the ELISAs, it's around 73%. You will detect earlier than C6, but the specificity is not good. With the IFA, it's a little better than C6 ELISA or the regular ELISA. We are around 80% in terms of sensitivity.
So
the specificity is around 80. So none of the tests that we have on the market today should really be used as screening tests. You think about it, you have 80%, and then your sensitivity on your Western blot is 80%. So you already miss almost 40% of your patients.
Is it fairly common that people that reach out to IGeneX even order these tests, or?
Some do because of insurance. Some insurance require you to do a 2-tier test.
Okay.
So you do have to offer them.
And my understanding is that the ELISA, the Lyme IgM, IgG serology, that is specific to Borrelia burgdorferi and not a lot of these other Borrelias that we've been talking about. Is that true?
That's true.
Okay, very good. So you mentioned IFA. Tell us a little bit about what is the IFA technology and how is it different from a blot?
Okay, so IFA stands for immunofluorescence assay. Basically, what we do is, in case of IFA, we have a glass slide on which the Borrelia are fixed, the whole cells are fixed. So you're not lysing them, you just fix them, and then you come with patient's serum. If the patient had antibodies, they're going to bind to this Borrelia. And then we come with a secondary antibody with a tag on it, in this case a fluorescent tag, so that if the patient had antibodies, the cells will fluoresce. And you'll see Borrelia cells fluorescing when you look under the microscope, and that tells you whether the patient had antibodies or not. Now, the difference here is that you are looking at the whole cell. And as we said, there are some antigens that are going to be specific for Borrelia, some are going to be across the genus.
So the IFA is broader than just Borrelia burgdorferi?
Yes, okay. It is.
Okay. And then when we look at some of the antigen-based tests that you have, talk to us a little about what is a PCR, and then what organisms does the IGeneX PCR for Lyme specifically looking at?
Sure. So PCR basically is a way of detecting DNA, pathogen DNA, in a clinical sample.
So this is a direct test now.
It's a direct test now. And so what happens with PCR is that you design specific DNA pieces, and then you you purify the DNA, you bind those pieces, and you extend them. So you make more copies of the pathogen-specific DNA, a piece of that. And then you can detect it by several methods, by having a probe with a DNA sequence which binds to it with a tag that you can look under a microscope, or do gel analysis, or have a color development reagent at the end, so you can see whether it's positive or not. So basically what you're doing by PCR is finding that piece of DNA, amplifying it so that it's visible, and it's very, very specific because it's looking at a DNA signature, which is very specific to Borrelia. Now, in case of the test that IGeneX has developed for Borrelia burgdorferi, it's designed to detect Borrelia burgdorferi sensulatum, meaning it detects the US species. We know that it will detect Borrelia burgdorferi B31, 297, Mayoni, which are the ones, Spilmani. And from Europe, we know it will detect Evzeliae, Guarini, Valenciana. So it's the way it's designed. Again, our approach for everything is we want to be very inclusive. But it will not detect Tick-Borne relapsing fever Borrelia.
So I think you mentioned earlier that the sensitivity of PCR in general is not very high. Is that right?
Yes. The reason is Borrelia like to hide in tissues. And it's not the tissue, you don't know where they are in the tissue, so you can't just go and do a biopsy of a tissue. If you had an infection with an EM rash, for example, when you just got infected in the skin biopsy, you're most likely going to be very positive. But if we are looking at the full spectrum of the disease, it's about 30%.
And my understanding is the IGeneX PCRs that you do offer a Lyme PCR, which looks at Borrelia burgdorferi, the European strains, Mayonii, and that there's also now a PCR for the relapsing fever Borrelias. Is that right?
Yes, and again, the same approach, we do the genus level and we speciate it to Borrelia miyamoto and some of the other species with it.
What about some of the urine tests that you in the past, like the Lyme Blot, for example, with all the advances you have with these other, the Immunoblot and so on, is there still a place for the Lyme Blot urine test as well? And when would we use that?
Okay. Yes, the Lyme Blot is useful because first of all, urine sample is non-invasive. For children, it could be very useful to look at. You are looking at the antigen in the urine. Also, I would like to point out that PCR in urine is very useful. We are finding that in a study that was done on 107 patients several years back with Dr. Harvey, we found that the positive rate, these are all untreated patients, the positivity rate in urine was higher than in blood in those patients, non-treated patients. And this was not like it was done at the same time. Samples were coming in over 2 years. So we looked at everything because the question was, maybe there was a contamination. That's why you got it higher. That was the first thought. We looked at it. You are getting 1 or 2 samples positive in a whole run. There was no way it was contamination. And we do believe that the urine test, PCR test does work well. Most people are not really ordering that right now because they will order the blood test. If they get the answer, there's no need to go further. But if they don't, this could be a very useful test.
And for kids, that makes a lot of sense where they don't want to do a blood draw. It's nice to be able to have a urine option. Let's talk a little about the Igx Spot, which is a newer test, my understanding that IGeneX is offering, that it's a T-cell based test. So what is that test looking at, and when might that be considered relative to some of the other tests that you offer?
Okay, so the Igx Spot looks at the T cells. T-cell response to the pathogen, in this case, Borrelia burgdorferi. So when a patient gets infected, T-cells, specific T-cells come into play, and we are trying to detect these T-cells. And from our experience, we found that this test could be useful early in the disease, but during the time when the antibody levels are very high, when you have G and M present, this test is not working. So it looks like once the T cells have triggered the immune response, IgG and IgM, it's not working. But later in the disease, when the levels have gone down again, we are able to see a T cell to be positive. This test could be useful in patients who do not make antibodies.
And is it potentially useful then after someone's been treated for a long period of time to see if they potentially should continue treating, or if their Lyme is essentially gone dormant or in remission in some way?
There have been suggestions that this test could be useful, and the recommendation is usually 6 months after the treatment has been completed that you should test for it. I personally have no experience. It's a very new test for us.
Yep.
We have to wait and see.
So I know there have, over the last several years, there's been various spot tests of different types, and I'm not going to specifically mention the commercial names of these other companies, but is the technology similar to some of those other spots that's been around, or is there something unique about the Igx Spot?
Okay, the technology is similar, but what the key really is what antigens you use. The quality of the antigens, the specificity of the antigens, that is very important. And we believe that what we have done with our experience and the knowledge with our immunoblots, we believe that we've chosen the right antigens. That it could be more specific. I can't answer that question, but that's what I think.
And is it true that the Igx Spot is currently limited to Borrelia burgdorferi, or does it show other Borrelias as well?
It's Borrelia burgdorferi right now, the test we are offering. We are working on other tests.
Great, great. Let's talk a little about co-infections, because I rarely find people who have Borrelia that probably don't have some co-infections as well, if only it were that easy, but it seems like it barely is. So with Bartonella and Babesia, and I know you offer a FISH test for both of those. So can you tell us a little about FISH testing? What is that technology?
Okay, FISH stands for Fluorescence In Situ Hybridization. In simple terms, it's a staining technique. So basically what you do is you make a blood smear, just like you would do for malaria. When you go and get your blood tested, they make a smear and they test it with a stain. In this case, we come with a very specific DNA probe targeted to ribosomal RNA. The reason we choose ribosomal RNA as a target, it's highly abundant in a cell compared to DNA targets. You can have 10,000 copies of it. Not only that, it's not in the nucleus, it's in the cytoplasm. So when the sample is positive, say it was Babesia and the patient had Babesia, it will light up the whole cell. So it gives you morphological information, just like staining does, but at a very high, the specificity is extremely high because you're looking at very specific sequences of that pathogen. And it will fluoresce, so it's easy to see that. Also, because you're looking at RNA, it's looking at active infection. Okay? With DNA, with PCR, it's a great technique. Yes, there are certain disadvantages because when you do PCR, you have to go through purification steps. So there are losses. Secondly, DNA persists for a much longer time than RNA. RNA, if the cell is dead, you're not going to see it. So it's a good marker. It tells you it works very well in our hands because it's a fairly, just to give you an idea, New York State Department, I have to thank them for all the help they've given us on this project. Really, for 10 years, they provided us with proficiency samples. Proficiency samples are blinded samples sent to you 3 times a year. So we were getting 15 samples every year. We had to test them and send them the results. Sometimes could be 1 Babesia positive sample, 4 negative, sometimes none. And we had to identify or report our results on FISH and PCR. Over 10 years, we had done 155 samples total with them. Out of that, we correctly identified 153 samples. And one sample we missed by FISH happened to be probably had the Babesia had died in them, we believe. That's why we couldn't see it because our PCR was positive. The other sample, we are not sure whether contamination occurred, but there was contamination and we realized that, and that is why that sample was false positive. So we really think it's really great specificity for the test. In terms of sensitivity, I cannot answer that question because you really need well-defined samples where you can do low levels and high levels.
So for co-infections like Bartonella and Babesia, you offer an IFA, a PCR, and a FISH test, correct?
Correct.
And then for the Bartonella FISH, is that showing a large number of Bartonellas, or is it specific to either Quintana or Henseley or?
No, the approach we have taken is to go for a genus level test when it comes to FISH because we don't know if there are variants. Like for example, with IFA, if there are variants, you are going to miss them. That is what we knew. So we said that's not a good approach. We don't know what's out there. So we should really go with something broader and see what we find. And so we went, when we developed the Bartonella test, just like Babesia, we developed a genus level test. And then once we developed the test and we had some positive samples, what we did was we did PCR amplification on the FISH positive samples to see what were we finding. Is the test specific? Because we had nothing to compare it with. What are we picking? What surprised us was that we were not just picking Bartonella, Quintana, or Henseley. There were other species that we were picking up, Winsoni. But There was another, Vincent Elizabeth was another one that we picked up in there. So there were more species that we had not heard about or knew nothing about. Besides, Hensely is the most common, and Quintana. I mean, there have been a few cases of Vincent reported now, but not a common test.
So in the Babesia fish realm, then, since it's a genus level test, we would expect that would potentially identify Microti, Duncani, Divergens, any of those types of Babesias. The fish test could potentially identify those, correct?
That's correct. And we verified that, at least in US, because we had enough samples. We've shown that when they are positive by fish, some of them were Microti, some of them were Duncani.
Okay, very good. Yeah, it's nice to see how much these tests are advancing over the last several years. You guys are doing a lot of great research, it sounds like. So let's talk about some of the other co-infections like Ehrlichia, Anaplasma, and Rickettsia. So in that realm, and those are all kind of related, the Ehrlichia, Anaplasma, and Rickettsia. So my understanding is you do an IFA and then a PCR, but not a fish test, for example, right?
Correct. At this point, we are not doing fish tests because, but we are in the process of developing some of them.
Okay.
Because we think that these are going to be very useful based on our experience with Babesia and Bartonella.
Very good. So tell us a little bit about your thoughts on the CD57, which for many years was not available from IGeneX. I know a few years ago you started offering the CD57 as well. What are your thoughts? Is it a good marker initially? Is it a good marker to track progression of treatment? What's the latest on the usefulness of a CD57?
Okay, CD57 really is a marker for chronic infection. That's all. So, for example, if a patient had positive Lyme tests and the CD57 count was low, then one would say that the patient most likely has chronic form of the disease. Okay. But just because CD57 is low, it doesn't mean that you have Lyme disease.
Right.
So that's how it works.
And it sounds like in some people that do have Lyme disease and get treatment and symptomatically recover and feel very good, CD57 doesn't always seem to normalize.
That's true. And I know people have said that it can be used to monitor patients during therapy. I think the thoughts are changing on that now. Mm-hmm. That because of the variation they were seeing, they thought that was really true. But studies done later show that is normal variation you are seeing. It's not something that is telling you whether the whether the patient is responding or not. There have been suggestions that it should be done 6 months after the patient has been treated. I don't know, because we really don't get those kind of samples.
So if someone is just starting to explore the potential for Lyme disease with their doctor and has really no idea whether they have Borrelia, which co-infections, what tests do you think are a good first set of screening tools to evaluate for the potential of Lyme and common co-infections?
Okay, I think throughout our discussion today, I have always found the panel approach to be the best. So we have a borreliosis panel. It's the one I've been suggesting to most patients now, because you don't know what you have. Do you have Lyme? Do you have both infections? Then you need or one or the other. And it's really the immunoblots and PCR for Lyme that I've been recommending, because I don't have this much experience with tick-borne relapsing fever PCR at this point. So at least the Lyme we know definitely is helping us. I don't know whether that's the same for tick-borne relapsing fever as yet. So we recommend that on our panel is LTP2 is the panel that I recommend. And then for the co-infection, we have one, because if I were to give you the statistics, like for example, we're looking at the data from 2013 and 14 between them for 1 year. 10% of the ticks we tested were positive for Lyme. Around 3 to 5% of the ticks were positive for Babesia, Ehrlichia, and Rickettsia. Bartonella, we didn't find that many ticks positive. We didn't find any tick in that year that was positive, because there's still a question mark. Is the Bartonella transmitted by ticks or is it transmitted by something else?
But have you, outside of the 2013 to 2014, have you found any ticks that had Bartonella?
Yes, we have found 4 ticks to date now.
Okay.
Okay, so the numbers is low, but we have found some. So that is why we have a co-infection panel 3, which looks at Babesia, Bartonella, Ehrlichia, Rickettsia. Yep. So
okay,
that's
very good. Yeah, that's great. So I wanted to kind of see, are there any tests? We talked about this a little bit, but just to get your thoughts on, is retesting along the course of treatment a useful way to see if treatment has been successful or not? And what does it mean if someone does a Western blot or an immunoblot, years of treatment in, they're feeling pretty good, but they still show some positive IgM bands on an immunoblot? Does that mean that they still potentially have an issue that needs more treatment, or might that mean that their immune system is now reacting to a small number of organisms that are left in a healthy way that it should be actually responding?
very good question. I really don't have an answer to that one because, I've been trying to follow some of the patients, but it's really for short time. As I said, the 1 or 2 patients which we have followed over a year, Morgellons patient, we didn't see any change in them, but they are still sick. Mm-hmm. But I think at this point, if you're feeling well, that's a sign. Keep up whatever you're doing is working. And to monitor yourself is not a bad idea, because if you do see a change in the pattern, then maybe you need to start taking care of it before it gets into a stage where...
And it sounds like the Igx Spot may, over time, emerge as a test that could be helpful to see if there is still that T cell activity even after treatment, right?
Yes.
Yeah. So you mentioned Morgellons. That's a topic that I have done a podcast on with Ginger Savely. Uh-huh. It's a condition that my heart goes out to people that are dealing with that. And it's interesting, the connection between Morgellons and Borrelia, that it's very common for people with Morgellons to also have Lyme. So tell us a little about the research that you've done in that realm. What did you find? What infections were identified in those people with Morgellons?
So we did a study on 32 well-defined patients. And this was a very extensive study. We looked at all the tick-borne diseases in them. Most of them happened to have borreliosis, either Borrelia burgdorferi or tick-borne relapsing fever. These are the 2 markers we found in them. And then the other marker we found that was positive was Bartonella. We found skin biopsies that were positive by PCR, blood samples that were positive by PCR in these patients. It was interesting that they were positive by PCR. We didn't find any, antibodies or anything like that, but PCR was positive for Bartonella. For Lyme, we had antibodies present as well as PCR positive.
So Borrelia and
Bartonella are the 2 we found in these patients. Mm-hmm. We didn't find Babesia or Ehrlichia in any one of them.
Very interesting. Yeah, I've heard people speak, Ginger Savely talk about the connection to Borrelia and also to Bartonella, and that in many of her patients that the Bartonella treatments seem to be the ones that help symptomatically in Morgellons patients in many cases. So it sounds like correlation there as well.
Yep, and it was interesting that we found it in skin biopsies as well, by PCR and by fish.
Yeah, very interesting. So if someone has a tick bite, I just want to make sure people are aware of the tick testing options that IGeneX offers. So what are the organisms that you can test for in a tick? And then when someone sends a tick, do they separately order each of the different co-infections, or is it one big panel? If someone wants to do tick testing, what do they do?
Okay, we don't do a panel, but for the tick, we offer tests for Borrelia burgdorferi, relapsing fever Borrelia, Babesia, Ehrlichia, which includes Anaplasma and Ehrlichia saphiensis, Rickettsia, Bartonella. So we cover all the co-infections that we offer tests for humans. We test it for ticks as well. And for ticks, it's a PCR test. for all these organisms.
And if someone has a tick and they're going to send it to you, but maybe it's going to take a little time, or they want to wait and see if they develop any symptoms before they get the tick tested, how should they preserve the tick so that your testing can later analyze it?
They can just put it in a small container or a Ziploc bag and put it in the freezer. That's fine. And then send it when they are ready.
And that can be done quite a period of time later, right? It
Yeah.
doesn't. Yeah. Okay, great. So tell us a little about, if people are interested in testing with IGeneX, how they get test kits. Does it generally get covered by insurance? And what are some of the resources that can allow people to access IGeneX testing if they have financial hardships?
Okay, so let's start with the test kits. On our website, you can go ahead and order a kit online. And now one of the things we've done is we are charging everybody $20 per kit. And the only reason we are doing it, they get it back when they order the tests. So it's credited towards the testing. The only reason we are doing it is to stop wastage. We are finding that, there were a lot of wastage. Why do that? Mm-hmm. So that's the only reason. It's as easy as that, going online and ordering a kit.
Okay.
We send to their house, they'll put in their address, goes there.
So they don't need a doctor to order the kit, but they do need a doctor to sign the requisition.
Yes, they do need a doctor to sign the requisition. And when it comes to what about the hardships, we have a TAP program that we participate in, and more information can be obtained from our office on that. But on the Lyme Disease org site, there are support groups. So support groups are the ones who are helping patients financially as well. So the best resource would be for them to find their local support groups and talk to them, and they can help them out.
And then the insurance side of it, is it fairly common for, I don't think you take insurance, but is it common for people to then file it themselves and get some coverage, or is that difficult to predict?
Okay, so we do cover Medicare, but what we are trying to work on, because we know this is trying to get file yourself for insurance is not an easy task, especially when you are not well. So we are working on a system where we've just started, we are testing it right now to see how we can help patients file for their claims to their insurance company at no charge to the patient. This is a service we are working on. So if anybody, does the testing and they want us to try it out, we will be willing to do that. Right now, we've just started that. At this point, we are in a learning stage. We don't know how it's going to work, but we are hoping that whatever we can, insurance gives, will directly go to the patient. So we fill the forms out for them and submit everything for them. They don't have to do anything. If it goes through, they'll get a check coming to their house.
Okay, that's great. That's a great service that you guys are offering. If someone suspects that they might have Lyme disease, but they don't know who in their area would even be willing to order an IGeneX test, for example, can they contact your office and get a referral to a local doctor?
Sometimes we can help, but the resources which are out there are very useful. Is the Lyme Disease org. Yep. They have a list of physicians that you can go to. They are very... that's one side. And the
ILRAD.
Other one is International Lyme Disease Association. ILRAD, they have a website that will help patients.
So
really are very good.
ILADS.org, for people listening, they do have a doctor finder on the site there that you can access Lyme literate physicians that can certainly order IGeneX testing. So that's ILADS.org. So what's coming next for IGeneX? What are the things on the horizon that are really exciting you right now? I can tell you have a lot of passion in this arena. So what's exciting you?
Okay. So we've been here in Bartonella. Bartonella is the other 3 Bs, right? Borrelia, Babesia, and now Bartonella. We believe that it is a big problem, especially in children. This is something I'd learned years back when I was giving a talk at New Haven, University of New Haven. There were a lot of parents there, and they say their kids were doing fine, and suddenly they're not doing well in school. They're suffering. So one of the first questions I had asked is, do you have pets? most of them had pets. So the question was, is it Bartonella? But we were never able to prove it with the test we had because we were really looking at Bartonella hensleyi and Quintana. But now we know that we found a lot more patients who have other Bartonellas that are causing the disease. So look out, that's our new test. We are coming out with a panel approach for Bartonella, where we will be looking at several species. Hopefully within the next 2 months, it should be out there.
Excellent.
And Igx Spot for Bartonella. So 2 tests to look forward to.
Wow, that's exciting. Igx
Yes.
Spot for Bartonella as well. So what are some of the key things that you personally do on a daily basis in support of your own health?
Basically, eat well, sleep well, not to miss any meals, but eat healthy, exercise.
And avoid the ticks.
Yes, try to. I think I've become immune.
Well, probably, right? It's interesting. I'm sure you've been exposed just from all the work you do in the laboratory environment. So maybe you do have a different immunity from many of us.
It's possible, right? Having been around them for 25 years.
Yeah. So this has been super, super fun. It was really informative for me. I mean, I personally used IGeneX for my own health journey back in 2005. And so IGeneX has played a key role in my own journey. But you advanced the testing so much. You've released new tests towards the end of last year, like the Immunoblots. And so it's great to hear what you guys are doing to continue to research, to provide new tools to help people identify the core underlying causes of their health challenges. And so I just want to honor you and thank you for all the work that you're doing through IGeneX and all the work you're doing to help educate people and the time that you've taken out of your busy schedule to be here today. So thank you, Dr. Shah.
Thank you very much. It was nice talking to you, Scott.
All
Take
right.
care.
Talk to you soon. To learn more about today's guest, visit IGeneX.com. That's IGeneX spelled IGeneX.com. IGeneX.com. Thanks for your interest in today's show. If you'd like to follow me on Facebook or Twitter, you can find me there as Better Health Guy. To support the show, please visit betterhealthguy.com/donate. If you'd like to be added to my newsletter, visit betterhealthguy.com/newsletters. And this and other shows can be found on YouTube, iTunes, Google Play, Stitcher, and Spotify.
Thanks for listening to this Better Health Guy blogcast with Scott, your Better Health Guy. To check out additional shows and learn more about Scott's personal journey to better health, please visit betterhealthguy.com.